basically
Yes.
today, these are tips and tricks. Well, not tricks, but tips about how you do well in the new clinical format. Of course, everyone know now that the clinicals nowadays are in the virtual format, which means that there's no real patients, which is quite a bit of bizarre way of examining patients and doing the clinicals, especially in the exam. So this presentation is to familiarize you what will happen and what the examiner wants you to say and do. Because it is more or less like a presentation and then a play. If you play it correctly, you will pass and get high marks. So, first of all, this is the exam format. It's the same format for every exam FRCS trauma and orthopedics, which is basically 2 intermediate cases, 15 minutes each, divided into 5 minutes history taking, 5 minutes examination, and 5 minutes discussion. The change here is that there is no patient. 3 upper limb short cases, 5 minutes each, and 3 lower limb short cases, 5 minutes each. This is what the examiners have and study before seeing you. This is how they are going to evaluate you. If you can't see my browser here, I would like you to be more or less in the 7 category, not in the 6 category. Because the 7, you will not have all of them, all the vivas and the clinicals at 6. You will go for some 5s. So if you're aiming to 7s, you're passing the exam. And today we are discussing how do you do the 7s in the clinicals. So, first of all, the intermediates. My experience with the intermediates and from the candidates who go to the intermediates, if you do well in both intermediates, that's about a quarter of the whole exam. No one passes the intermediates with 7s or something like that. And I haven't heard about someone do very poorly in the rest of the exam to actually fail after passing the intermediates with high grade. First thing with the intermediates is basically the history. And the history here is basically that the examiner telling you what do you want to know from the history. So the start is you have something old patient, like a 60-year-old patient with problem walking. That's it. What do you want to ask about the history? This is a bit of a weird atmosphere to any doctor, especially an orthopedic surgeon, not to have the patient in front of him, but have the examiner asking him, what do you want to ask the patient? The more difficult, as every question in the history can be asked about why are you asking it? And that's the point, that you have to justify them. Like, why are you asking about family history and neurofibromatosis? And you should have an answer to that, which is roles and families, and it's an autosomal dominant. I know that you know that, but the examiner don't. So the examiner has the right to ask you if you are asking an unfamiliar or an unusual question in the history. Next thing, what are they expecting to hear from the history? The point in the history is that first, you have to be a professional orthopedic consultant. I will tell you how to do that in the next slide, but think of it about that you are standing next to your consultant and he is asking questions to a patient. He will not ask about, his, like, what breakfast did you have yesterday? How long was your golf course? And these things. He will ask specific questions to try and minimize his differentials. Quality of the history obtained. You have to have a good history quality, which is organized, and they will tell you how to organize history taking by grouping your questions. And that's the point. And to be honest, orthopedic surgery, we have two main groups of problems. Either the patient lost a function of something, of a joint or something like that, or the patient actually has some sort of deformity. It's very good that you have in your mind a set of questions, a set of groups of questions that you want to ask. We will go through them. You have to ask about a relevant type of history, not an irrelevant type of history. Like, no, don't ask about the fracture of his little finger, which happened 3 years ago in a patient who can't walk. That's not good. Ability to communicate with the patient. And this is a very common question. Please consent the patient for a total hip replacement or a total knee replacement. Of course, can be asked in the discussion or can be done in the history as well, especially in the short cases. Social implications of the condition. Have you asked about this? Have you asked about what will happen after this patient has his joint replaced? Does he need any social support? Is he happy? Does he have his wife with him or anyone to support him after the surgery? What's his comorbidities? Is he on blood thinners, for example? You need to bridge. Ability to summarize important history points at the end. And usually the training is that you are doing 3 to 3.5 minutes of history, 4 minutes by most, okay? Half a minute to ask about the social, the comorbidities, everything, and at the end for the last half a minute to summarize the history point and give a differential diagnosis. So, first of all, please don't forget to introduce yourself. So after introducing myself to the patient, I will ask him about his present condition. And the present condition, as I said, can be either deformity or inability to do something. So for the deformity, for example, there is a set of questions. First, you have to ask about the deformity itself. Think about it as if it is scoliosis. When did it start? How did it progress? Is there any cause, like trauma, infection, tumor, anything like that? And whether or not there is any family history associated. Then associations of the deformity. If, for example, radial club hand, what are the associated conditions? What are you asking about? Is there any pain associated with this deformity? And the questions related to pain, onset, severity, what makes it worse, what makes it better, night pain for red flags, and what are the associated neurological symptoms. Then the red flags. You have general red flags for weight loss, anorexia, nausea, night pain, and you have red flags for the spine, which is you would ask about loss of bowel and bladder control. Treatment so far. What treatments did he have? Did he have physiotherapy? Did he have previous surgery? Did he have painkillers? Patients' expectations. Some patients are, no, I don't want anything about it. I just want the pain to go away. Some patients, no, I want to go back to play my tennis. This is unrealistic expectation. Past medical history, again, the relevant part. So let's go back to what to do after that. After that, you have to go for drug history. But again, There will be a very long list of drug history with every patient. You have to go for only the relevant ones that will affect your planning, like anticoagulation, steroids, any DMARDs, any diabetes, social history. In the upper limb, you have to ask about the hand dominance and occupation. And at the summary, you have to start your sentence with 60-year-old carpenter right-handed. The smoking status, especially if you're dealing with something that involves bone healing. Summarize to the patient, which is the examiner in this case. So if you go with this in your mind, you want to reach a diagnosis through the history by grouping up your questions and adding what do you want. If you have a mental block and you lost your concentration and you can't remember a single word of what I said till now, remember 3 points. What is the presenting complaint? What treatment so far? And what is the patient expectation? If you ask these 3 questions, okay, most of the history is done. And then give the examiner the differential diagnosis. Now, after doing so, you have reached more or less a differential. You have to go for the examination. This is the bit that has to be tailored to the patient according to the history. Don't examine a patient with age of 20 to 40, for example, with previous dislocation of the shoulder, and you are doing some sort of examination for osteoarthritis of the shoulder, or not a patient who is 70 years old, who can't actually mobilize his shoulder, and you are examining his shoulder stability. Because in real life, you're not doing that. And for the examiner, oh, this candidate doesn't know what is he doing. So no patients, just a clinical photograph. Sometimes they give you a video. This is more commonly in the short rather than the intermediate, but don't be surprised if you're seeing a video. Actually, either the clinical photograph or the video will give you a proper sign to describe and build up your case. Please start the examination, even in the virtual thing, after taking permission from the patient with adequate exposure and preservation of the patient's modesty. I would start by looking. So you start by looking. When you start by looking, you have a clinical photograph. So describe it, please. Describe what you see. If any troubles, like you can't see clearly a sign, or basically the photograph is very small, or you don't know what is this part of the body, well, ask the examiner. He will help you and he will guide you or magnify the photograph for you. There is no feel. So look, and then there is no feel. If you want to feel around the joint, ask the examiner whether or not there is any tender points. If important findings, then the examiner will mention. Then, of course, you will start by afterwards, for example, if it's anything in the lower limb, you will ask the examiner, I will observe this patient walking, and then I will do special tests. Then you will move the joint if it's an upper limb. So, for example, moving of the joints, so much important. So you're determining the range of movement of the joint. In the shoulder joint, don't forget to look from the back and isolate the glenohumeral movement by stabilizing the scapula. Then you do special tests and be prepared in both intermediate and short cases that the special tests, you have to know at least 4 points in it. What is the principle of doing the special test? What are the steps of doing it? What is the significance of having it? And what if there is a false negative or a false positive? And the most important, most common example is the Trendelenburg test. Why are we doing it? What's the steps, significance, and the false negative, false positive? Then after doing the examination, most properly, you have reached a diagnosis. And after reaching this diagnosis by having the history and the examination, you will ask for some investigations. The discussion is of 5 minutes viva. At that point, you have about 10 minutes of asking questions, taking answers, and you don't see a patient in front of you to remind you of what you have asked. So basically, you are allowed to write. Please, please, please write the findings, positive and negative. Then you will ask about a list of investigations. These investigations, you are expecting some positive findings for it. First, to confirm your diagnosis. Second, to basically plan your management, okay? And third is to be asked about this investigation if you are presented with one. Here is the ability to score your points, score higher points at 7. So you've done good in the history taking, you've done good in the examination, and now it is your time to shine. Now that you had the intermediate cases, be prepared for the short cases. And again, this is a whole day. This is 4 tables. This is by the short cases, you are having half of your marks. And short cases are equally important. Although the intermediate, if you lost it, that's a significant amount of your marks. The short cases, if you lost one, that will give the examiner not a very good idea about you or an impression. So short cases, again, you will be presented with a photograph, clinical photograph or a video, and this is showing a sign. Again, you have to introduce yourself to the patient and adequate exposure with modesty. But at that point, you have to start describing. Please don't mention anything about taking history in the short cases, okay? This is a clinical photograph showing a patient has, and describe what you can see straight away. So describe what you see. Then after describing what you see, if it's obvious, so do the differential diagnosis. So my most probable diagnosis is that. And one of the most common thing is rheumatoid arthritis hands, which there is polyarthropathy of symmetrical in fashion in both hands. That's most probably rheumatoid arthritis. Then you start examining the patient. Please, when you start examining the patient, it's your time. In the 5 minutes, you have to describe what you see. You have to do examination of the patient, you will be asked at least one special test to describe about the patient, and you will have discussion, at least 1 or 2 questions. So all that should be squeezed in 5 minutes. Don't start enumerating negative signs. Like, if you have a patient with cave-of-airs foot, you will describe it. This is a clinical photograph showing peekaboo sign, high medial arch. I am suspecting this is a cave-of-airs foot. I want to see the patient walking straight away. All right? Don't start enumerating negative signs. Like, this patient doesn't have clawing of the toes. I cannot see any callosities around his pressure points. I want to see whether or not this patient, see the patient knees, whether or not there is any varus deformity. This is wasting your time. The trick here is go straight forward to walk the patient and then to observe the gait and do the Coleman block test. Once you say the Coleman block test, you will be asked about it. Then you sit the patient and you look for the 3 S's, which is the shoes, sole, and stick. Any walking aids, shoe wear, and insoles, and any callosities in the sole. Then you will start examining this patient. Don't forget to look into 2 parts, hands and spine. Good. So special tests. What do you want from the special tests? Either to confirm your diagnosis or specify your diagnosis, like the Coleman block test, to see whether or not it is a flexible cave-of-airs deformity and whether or not it's forefoot driven, and to guide your management. Okay? Then, like tendon power in the cave-of-airs. Another thing, in the short cases, after going through the examination, straight away say, I would like to investigate this patient further by asking for a weight-bearing X-ray, if you are happy with your examination. And again, this is to confirm your diagnosis and for planning for the management. Usually, from my exam and the exams afterwards, there was no pre-prepared investigations like X-rays, MRI scans, or CT scans in the short cases. But that makes things a bit more difficult because you have to know what you are looking for and what is your expectation from having an X-ray. Like, what is the Mears angle or calcaneal pitch angle in cave-of-airs foot? Okay, is it increased or decreased? Then the expected findings. Management per road line. That's the next question. If you reach the management in the short case, you're doing really well. And the management road lines are basically non-operative, like if it's not painful and flexible, you can put corrective orthosis. If it's fixed, you could put a accommodative orthosis. And operative options. And the operative options, you don't have time to say, I will do this, I will discuss it with a senior foot and ankle surgeon or send it to a senior foot and ankle surgeon. Straight away, this should be operated on by a consultant foot and ankle, but the treatment options for a surgical treatment options are, and how I remember it, is 2 bony procedure, 2 releases, and 2 tendon transfers. So osteotomy of the calcaneum, osteotomy of the first metatarsal, release of the tender Achilles and the plantar fascia, and tendon transfers around the ankle. Thank you. Any questions so far?
Thank you very much, Joe. Very nice presentation. And I think that will highlight how the new exam format is, I think.